Hello and welcome to this weekly pelvic perineal literature watch for June 12th, 2026, presented by Erwan Lerumeur, physiotherapist in Paris. This is for information only, not individualized medical advice. References are available in the description. This week, the watch retrieved 65 articles. Today's topic is pelvic pain, and more specifically, the way rehabilitation, physical techniques, neuromodulation, and musculoskeletal assessment are now being tested with increasingly concrete clinical criteria. We will discuss dysmenorrhea, chronic pelvic pain with pelvic floor hypotonia, breathing, capacitive and resistive electric transfer, pudendal pain, hypermobility, endometriosis, remote myofascial therapy, artificial intelligence, and, toward the end, continence and quality of life. The central idea is simple. In pelvic pain, saying it is multifactorial is no longer enough. We need better patient profiling, better tool selection, better outcome measurement, and caution whenever the evidence is still preliminary. First section, top stories, 2 randomized trials directly relevant to pelvic floor physiotherapists. The first important article is by Yakıt Yeşilyurt S et al., published in BMC Women's Health. The authors assessed pelvic floor muscle training with or without dynamic neuromuscular stabilization-based breathing in women with primary dysmenorrhea. 66 women were randomized to 3 groups: pelvic floor muscle training plus DNS-based breathing, pelvic floor muscle training alone, or no intervention. The program lasted 4 weeks, with 1 session per week. Outcomes included menstrual symptoms, pain, and quality of life. The results are clinically interesting. Both active groups improved menstrual symptoms and pain scores, and benefits were maintained at 3 months. However, adding DNS-based breathing did not outperform pelvic floor muscle training alone. In other words, in this trial, the pelvic floor component appears to be the main signal, while the added breathing strategy did not provide a measurable additional benefit. The clinical message is useful. In primary dysmenorrhea, a short, structured, non-pharmacological program may reduce pain and symptoms, but protocols should not be overloaded with additional technical layers unless they demonstrate a clear added value. For practice, this brings us back to the basics: clear indication, simple progression, adherence, and reassessment. The second top story is by García Maestro, Ferry Morales, and Sierra in the European Journal of Obstetrics, Gynecology, and Reproductive Biology. This study focuses on chronic primary pelvic pain syndrome in women with pelvic floor hypotonia. The authors compared capacitive and resistive electric transfer, or CRET, with placebo. This was a multi-center, randomized, placebo-controlled trial. 44 women completed the study. All participants received usual care, and the active group also received a standardized intravaginal CRET protocol. Outcomes assessed pain, quality of life, and resting pelvic floor electromyographic activity. The results are fairly marked. In the CRET group, pain decreased more than in the placebo group, with a median visual analog scale reduction of approximately 40 to 50 millimeters. The improvement was maintained at 6-week follow-up. McGill pain scores also decreased, quality of life improved, especially in physical and psychological domains, and resting pelvic floor EMG activity decreased more in the active group. No adverse events were reported. This paper matters because it tests a physical technique already used in practice, but with a placebo-controlled design. It does not turn CRET into a universal solution. The sample remains limited, follow-up is short, and independent confirmation is needed. But in a specific subgroup, chronic primary pelvic pain with objectively measured pelvic floor hypotonia, the clinical signal is coherent. Pain, quality of life, and resting muscle activity all move in the same direction. Together, these 2 trials set the tone for the week. They do not say that every pelvic pain condition is treated through the pelvic floor. They say that in selected profiles, the pelvic floor is a measurable therapeutic target, and techniques should be assessed with clear criteria. Second section, understanding pelvic pain more precisely. To step back, Carey, Chu, Schiff et al. Published in Clinical Obstetrics and Gynecology a review on musculoskeletal components of chronic pelvic pain. The abstract reminds us that chronic pelvic pain affects up to 24% of women worldwide, and that musculoskeletal pain and dysfunction are present in most cases, yet often overlooked when care remains too organ-focused. The authors emphasize movement pattern analysis, pelvic floor examination, and assessment of hip, spine, and abdominal wall pathology. This is important In many patients, the clinical examination should not oppose gynecologic and musculoskeletal explanations. The real question is which structures contribute to the clinical picture. Pelvic floor, vestibule, hip, scars, abdominal wall, spine, nervous system, sleep, fatigue, fear of movement, or sexual avoidance. And this review is a clinical synthesis, not a treatment trial, but it describes a common problem well. If the assessment is too organ-focused, modifiable factors may be missed. Conversely, if rehabilitation becomes too generic, the diagnostic thread may be lost. The challenge is to connect local assessment, functional assessment, and testable clinical hypotheses. Pudendal pain appears in a paper by Badal, García, Lee et al. In the Journal of Vascular and Interventional Radiology. The authors retrospectively analyzed CT-guided Pudendal nerve cryoablation. Out of 202 unilateral procedures, 75 had adequate follow-up for the main analysis. They tested 3 selection criteria: an identifiable triggering event, unilateral perineal pain consistent with Pudendal distribution, and a positive response to CT-guided diagnostic Pudendal block. Overall, 65.3% of analyzed procedures achieved at least 50% pain reduction, but outcomes were much better when all 3 criteria were present. Response rate was 77.4% versus 36.4% when not all criteria were met. Mean pain reduction was also greater, 69.1% versus 29.5%. No major adverse events were reported. This is not a randomized trial, and it is not a physiotherapy paper, but its message is highly relevant for pelvic pain pathways. Patient selection matters. An invasive technique can look effective in a well-characterized subgroup, and much less relevant in a poorly defined population. For rehabilitation too, functional diagnosis and indication criteria are not administrative details. They probably shape a large part of the outcome. Still on interventional pain management, Benzon, El-Mofty, Shankar et al. Published in Regional Anesthesia and Pain Medicine Guidelines on corticosteroid use for sympathetic blocks, peripheral nerve blocks, and trigger point injections in adults with chronic pain. The document is broad, but one point is particularly relevant here. The authors report no evidence supporting corticosteroid use in Pudendal nerve blocks. They also emphasize potential corticosteroid adverse events, including blood glucose increase, reduced bone mineral density, and suppression of the hypothalamic pituitary axis. For pelvic perineal care, this matters. Many patients with pelvic pain move between physiotherapy, gynecology, urology, pain medicine, imaging, and injections. The physiotherapist does not decide the indication for a block, but should understand what is being proposed, recognize the level of evidence, and avoid presenting injections as obvious when the evidence is weak or context-dependent. Patient phenotypes are addressed by Barton, Moss, Ellis et al. In Rheumatology International. This cross-sectional analysis describes women with hypermobility, hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, and genitopelvic pain. The paper reports a high presence of provoked vestibulodynia in patients diagnosed with hypermobile Ehlers-Danlos syndrome. Among patients with provoked vestibulodynia, some had posterior vestibular allodynia, suggesting a pelvic floor hypertonia contribution, while others had more diffuse vestibular pain, suggesting possible inflammatory, neuroproliferative, or hormonal mechanisms. The limits are clear: cross-sectional design, specialized population, and no causal conclusion. But the study is useful for practice because it reminds us that pain with penetration does not always mean the same mechanism. In a hypermobile patient, the presentation may involve myofascial, vestibular, inflammatory, hormonal, anxiety-related, traumatic, or mixed components. The clinical value lies in not putting all dyspareunia into one box, and in testing hypotheses one by one. In endometriosis, Anbari Mogadam, Akunzade Nugabi, and Jahani and Sadat Mahale published in BMC Medical Informatics and Decision Making an interpretable machine learning model for classifying endometriosis using 1,489 records and 52 clinical variables. The rule-based model achieved an area under the curve of 0.906 for binary classification and an average area under the curve of 0.705 for disease stages. Key variables included pelvic pain, dysmenorrhea, dyspareunia, severe bleeding, tumor markers, age and body mass index. This kind of paper can easily attract attention because it involves artificial intelligence. The interesting point is not to promise automated diagnosis. It is the effort to provide interpretable rules that clinicians can read. But real clinical validation remains decisive. In endometriosis, where diagnostic delays and pain mechanisms are complex, artificial intelligence may help structure clinical reasoning. It does not replace examination, imaging, or specialist decision-making. Still around endometriosis and adenomyosis, Yi Liu et al. Published in Reproduction and Fertility a small pilot study on transcutaneous auricular vagus nerve stimulation. Only 6 patients were included, 4 with adenomyosis and 2 with endometriosis. Treatment lasted 6 months and appeared well tolerated, with pain relief reported at 3 and 6 months. The authors remain cautious, encouraging early results, but the study is far too small to conclude. This is a typical watch list paper. It signals a possible direction, not proof. It is interesting because it connects menstrual pain, autonomic regulation, and non-invasive neuromodulation. But in practice, it should not be sold as a validated treatment. It belongs in the category plausible physiological hypothesis, very preliminary clinical signal, need for controlled trials. Remote technology appears with Guattari, Bojorquez, Hubbard et al. In a Research Square preprint on the Smart Wand. The device is designed for high-tone pelvic floor dysfunction and chronic pelvic pain. The idea is to allow the therapist to map myofascial points in clinic, then guide the patient at home using information on insertion depth, rotational orientation, and applied force. The validation study included 20 women, 10 with high-tone pelvic floor dysfunction, and 10 healthy controls. The device showed excellent reproducibility for depth and orientation, and good reproducibility for applied force. This is a technical result, not yet a therapeutic outcome. It does not show that patients have less pain, but it asks an important question. Can an internal myofascial treatment, usually dependent on a trained therapist, become more accessible while maintaining precision and safety? This topic is sensitive. Home-based tools can reduce access barriers, but they can also create false shortcuts. In pelvic pain, especially when hypertonia, allodynia, or trauma history are present, autonomy has to be built progressively, and technology does not replace indication, consent, education, and follow-up. In the field of patient information, Gochman, Karasu, Chinar, Kuyuchu et al. Published in Digital Health an evaluation of ChatGPT 4.0 for patient education on urinary incontinence. 13 guideline-derived questions were submitted to the model in Turkish. Responses were judged highly understandable, especially for diagnostic explanations, but less actionable, particularly for surgical topics. Overall reliability was rated as fair, and most answers required a university-level reading ability. This paper is not specifically about pelvic pain, but it is very relevant to digital health communication. Patients may receive clear explanations, but not necessarily concrete, adapted, and accessible steps. In pelvic health, where symptoms are intimate, chronic, and often under-discussed, artificial intelligence can help explain, but it can also produce content that is too general, too complex, or insufficiently actionable. The professional remains necessary to turn information into action. A similar patient experience perspective appears in a study by Mansour, Fahmy, D'Amico et al. In International Urogynecology Journal on the implantable pulse generator used in sacral neuromodulation. Sacral neuromodulation is used for refractory urinary and anorectal disorders. The study surveyed 100 patients implanted within the previous 2 years. 62% reported awareness of the device, 18% reported sleep or movement limitations, 36% reported activity-related discomfort, and 11% turned off the device for non-MRI reasons. Leaner patients appeared more likely to experience discomfort. The message is straightforward. The efficacy of an implantable therapy is not limited to urinary or bowel scores. The device lives with the patient. Sleep, sport, sitting, body perception, device handling, and fear of malfunction all matter. Proper counseling should discuss expected benefit, but also the material burden. 2 continence papers usefully complete this episode. Tsuchiya, Yagi, Nishida et al. In Quality of Life Research analyzed more than 12,000 Japanese adults aged 65 and older. Overactive bladder affected 27.9% of participants and was associated with a clinically meaningful reduction in health-related quality of life. Quality of life declined as severity increased, and urgency urinary incontinence had a particularly strong negative relationship with quality of life. The self-care dimension was the most affected. Even though today's episode focuses on pain, this article reminds us of a clinical continuum. Pain, urgency, incontinence, fatigue, and quality of life often accumulate. Many patients do not seek help for an isolated symptom, but for a combination that gradually reduces freedom. In patients with multiple sclerosis, Cohen, Yeong, and Tam, in current urology reports remind us that lower urinary tract symptoms may affect up to 90% of patients. Effective management requires renal function preservation and quality of life improvement through assessment, behavioral therapy, pharmacology, botulinum toxin, neuromodulation, or surgery when appropriate. Erkan, Kocher, and Sitin in multiple sclerosis and related disorders add that neurogenic bowel dysfunction is associated with urinary symptoms, fatigue, and reduced physical quality of life. Again, the clinical value is to avoid artificially separating bladder, bowel, fatigue, and function. Last section, the briefs. First brief, Ferrari, Pisacreta, Bonciani et al. In Acta Obstetricia et Gynecologica Scandinavica, followed 10,576 women from pregnancy to 12 months postpartum. Fecal incontinence remained a minority condition, between 3 and 5.5%, but persisted in some women and was associated with several factors: age, overweight, high-risk pregnancy, operative delivery, perineal tears, episiotomy, higher birth weight, and difficult access to services. Importantly, in this cohort, pelvic floor muscle training was not protective. Second brief, Mala, Dumuchtis, Panay et al. In Journal of Clinical Medicine, analyzed obstetric anal sphincter injuries in a UK tertiary maternity unit. Among 9,586 vaginal births, incidence was 2.82%. Independent predictors included nulliparity, Asian ethnicity, shoulder dystocia, and birth weight of at least 4,000 grams. Episiotomy was associated with lower adjusted odds of OASIS, but the authors clearly state that this observational association should not be interpreted as proof of a causal protective effect. Third brief, Hashiramoto, Takita, Arakaki et al. In Scientific Reports, evaluated transperineal ultrasound before forceps delivery. After propensity score matching, ultrasound-assisted assessment was associated with fewer maternal and neonatal composite adverse outcomes, and fewer cases requiring 3 or more tractions. This is an interesting paper on imaging as a safety tool for instrumental delivery. Fourth brief, Nalda, Inostroza, Whipple et al. In International Urogynecology Journal, surveyed 366 female marathon runners. Stress urinary incontinence was reported by 33.9%, vaginal bulge symptoms by 23.5%, pain during sexual activity by 20.2%, and fecal incontinence by 7.1%. Race distance was not associated with symptoms. Age and parity mattered more. Fifth brief, Holder and Svenningsen, in International Urogynecology Journal, analyzed 34,280 mid-urethral sling procedures from the Norwegian registry. Surgeon experience and annual volume were associated with better objective cure after TVT, but the effect was small and was not reflected in the same way in subjective outcomes. Conclusion. This week's watch shows an interesting evolution. Pelvic pain and pelvic floor dysfunctions are increasingly approached through phenotypes, criteria, and measurable tools. Yakıt Yeşilyurt et al. Show that pelvic floor muscle training may reduce pain and symptoms in primary dysmenorrhea without an additional demonstrated benefit from DNS-based breathing. García et al. Provide a positive placebo-controlled trial on CRET in chronic pelvic pain with pelvic floor hypertonia. Carey et al. Remind us of the importance of a real musculoskeletal assessment. Battle et al. Show that Pudendal cryoablation outcomes depend strongly on selection criteria. Barton et al. Highlight hypermobility and genitopelvic pain. And the papers on SMART1, ChatGPT-4o, and sacral neuromodulation remind us that technology only has clinical value if it truly helps the patient act, understand, and follow treatment. The practical message is clear. In pelvic pain, we need to move beyond general statements, identify likely mechanisms, test hypotheses, measure response, and distinguish solid signals from exploratory leads. Thank you for listening. Always check the full papers and current guidelines before changing practice. References are available in the description, and see you next week for another edition.